Okay, my talk today, this session is on heart failure management in primary care, practical considerations in the use of RV. Now, when you look at cardiac injury and overload leading to heart failure with reduced ejection fraction, there are three systems that are activated. One is the sympathetic nervous system, two is the renin angiotensin aldosterone system, and the third is the natriuretic peptide system. Among these, we know from experience that sympathetic nervous system and RAS stimulation are deleterious in the long run. Whereas the natriuretic peptide systems are helpful and they have to be stimulated. That is what we know from the experience and the research is conducted all these days. So let us look at the natriuretic peptide system, because I'm sure there has been lots of discussions on sympathetic nervous system and RAS system earlier. Well, when there is wall stress in the myocardium or even in the left atrium or even in the atrium, the natriuretic peptide systems are stimulated, which lead to release of A-type as well as B-type natriuretic peptides, which in turn act on the natriuretic peptide receptor A, which stimulates guanylate cyclase A, increased production of cyclic GMP, increased production of phosphokinase G, and the good effects of natriuresis, vasodilatation, and reduced fibrosis. Now, ANP and BNP also has some amount of RAS blocking effect because it blocks the production of renin also. Now, ANP and BNP are degraded by an enzyme called neprilysin. And so if you give a neprilysin inhibitor, you can increase the levels of the natriuretic peptides and thus stimulate the natriuretic peptide system. Now, let us for a minute come back to the sympathetic nervous system. As you can see here, we have beta blockers, which blocks the sympathetic nervous system. And now, as far as the RAS system is concerned, we have ACEI, which blocks the conversion of angiotensin 1 to angiotensin 2. We also have ARBs, which block the action of angiotensin 2 on the AT1 receptor. And finally, we have mineralocorticoid receptor antagonists, which block the action of aldosterone on the receptors. Now, all these on the left side have been tried, found to be useful. So that side is now saturated as far as treatment of heart failure is concerned. Now, on this side, the only drug that has been tried was a synthetic natriuretic peptide, and unfortunately it did not show any benefit. That is nesiritide, which did not show any benefit as far as reduction in mortality or morbidity is concerned. And that is why researchers put their concentration on this neprilysin inhibitor. Now, why ARB? Why can't you give only a neprilysin inhibitor? Why do you want to add it with an ARB? The enzyme neprilysin degrades many endogenous vasoactive peptides, not just natriuretic peptides. It also degenerates adrenomedulin, bradykinin, substance P, calcitonin gene-related peptides. And all these proteins reduce neurohormonal activation, produces vasodilatation, reduces cardiac fibrosis and hypertrophy, and reduces sodium retention also. All these are blocked or rather degraded by neprilysin into an inactive metabolites. So when you give an IV infusion of natriuretic peptides, it does not lead to benefit because the natriuretic peptides are immediately degraded to inactive metabolites by neprilysin. And that is where people started thinking about neprilysin inhibition. Unfortunately, neprilysin also breaks down angiotensin 2, which you know is a vasoconstrictor. So neprilysin inhibition leads to increased levels of angiotensin 2, a vasoconstrictor, and that offsets the vasodilator effects of natriuretic peptides. And so neprilysin inhibition has to be combined with an inhibition of the RAS system also. When neprilysin inhibitor was combined with ACEI, both of them increased the levels of bradykinin, and so there was increased incidence of angioneurotic edema. And so it was this new combination of sacubitril with valsartan was made, that was known as LCZ696, and the trial was paradigm heart failure, comparing ARNI, that is a combination of sacubitril and valsartan, with enalapril in patients with heart failure and reduced ejection fraction. Well, this is a fairly large trial, more than 8,000 patients with NYHA class 2 to 4 heart failure. Ejection fraction initially was considered 40, but then it was down reduced to 35% with a raised BNP. And this is important. Patients were already able to tolerate a dose of AC inhibitor or ARB. These were the group of patients who were included. They were all on beta blockers and mineralocorticoid receptor antagonists. And the last criteria is also very important. They took only patients who had a systolic BP of more than 95, an eGFR of more than 30, and a serum potassium of less than 5.4. Among all these inclusion criteria, I think the last one is one which you have to keep in mind, because these are also contraindications. When low systolic BP, low GFR, and high serum potassium are the contraindications. As I said, this is one of the largest trials. The next trial is SHIFT, which contains about 6,500. So about 2,000 more patients than the next trial. And well-treated patients, 93% on beta blockers, 60% on MRAs, and 100% on RAS blockers. So well-treated patients. And the results were cardiovascular death and heart failure hospitalization. You can see that there is a reduction of 20%. And look at the number of zeros behind the p-value. You hardly see such values in medicine. You have to treat just 21 patients to prevent an episode of cardiovascular death and heart failure hospitalization. Look at cardiovascular death, similar story, 20% reduction, a number needed to read just 32, and a p-value of, again, several zeros below before the 8. And finally, all-cause mortality, equally good results, 16% reduction with a p-value of less than 0.001. Mind you, this 16% reduction is on patients who are already on beta blockers, is on patients who are already on mineralocorticoid receptor antagonists. Now, it is not only that the benefits were very good, but you can see that the curves are diverging as time passes on. Even at the end of 12 months, it is still diverging. And equally important, the benefits start very early. You can see that the curves have started diverging at the end of a month. So you see the benefits very, very early. In fact, if you give an angiotensin receptor blocker or an ACE, you get a reduction in mortality of about 15% or 18%. Now you change that to an ARNI, and you find the benefit of 20% reduction is over and above this 15 and 80%, which means you get an overall mortality reduction with ARNI of about 35 or 38%. Well, and the mortality benefits are across all causes of death, whether it is cardiovascular causes, whether it is death due to sudden cardiac death, or death due to worsening heart failure. All forms of death are reduced by LCZ 696. So let us now, with that introduction, let me now come to practical considerations in clinical implementation of giving these drugs. Let me talk about whom to treat, how to start and titrate, and finally how to follow. Let us start with whom to treat. Well, the patients included in Paradigm heart failure trial were stable ambulatory patients in class 2 to 4. So asymptomatic patients were not included, acute heart failure was not included. They should have a raised pro-BNP to suggest that they are still having LV dysfunction. Heart failure hospitalization in the last 12 months. They should be already on ACEI, ARB, and possibly a beta blocker and an MRA. And as I said, the three important criteria, systolic BP more than 95, potassium less than 5, and an eGFR of more than 30. And no angioedema during the last 2 weeks. How to start and titrate? In the normal course, you can start with 100 milligram BD. And after 2 weeks, you can double to 200 milligram BD. If the patient is already on an ACEI, you have to wait for 36 hours before starting ARNI. Because as I said, if you give an ARNI and an ACEI, the chances of angioneurotic edema are very high. So wait for 36 hours if the patient is on an ACEI. Whereas if the patient is on an ARB, there is no problem. You can start simultaneously. You can stop ARB, and the next dose you can give the ARB. Now titrates, increase the dose only if there are no adverse events, no hypotension, no hyperkalemia, no excessive reduction in GFR. In patients who had not been on full dose of ARB, or in elderly people, patients with moderate hepatic deficiency, or people who already have a low BP, you can go for a conservative approach. You can start with maybe 50 milligram BD for 2 weeks, and then increase to 100 milligram BD for 3 weeks, and then maybe increase to 200 milligram twice daily. And how to follow up? Well, follow up is basically these three things: potassium, blood pressure, and GFR. Blood pressure should be monitored daily, preferably for signs of hypotension, at least during the first few weeks, preferably to have a home BP apparatus monitoring so that you can look for evidence of hypotension. Creatinine and potassium again has to be evaluated regularly at the first week after starting, then every 2 to 4 weeks for the first 4 months, and then every 4 months. If nothing happens during the first 4 months, it is very unlikely that anything will happen subsequently. So then once in 4 months is good enough. If there is hypotension, especially symptomatic hypotension or hyperkalemia, then you can reduce the dose to half, wait for 2 weeks, reassess the blood pressure, reassess serum potassium, and maybe increase the dose if the potassium comes back to normal and blood pressure comes back to normal. So reassess for dose adjustment after 2 weeks. Monitor closely for serious adverse events. And it is recommended that these patients should preferably be going to a specialized heart failure center because they require close supervision and monitoring. I will only talk about these 3 considerations because these are the most important problems: blood pressure, potassium, and renal function. Now, when there is a drop in potassium, the most commonest reason is that the patient is dehydrated and is over-diuresed. So the best option is to assess the volume and sodium status, salt and water status, and then maybe try to reduce the dose of diuretics rather than reducing the dose of sacubitril/valsartan combination. Of course, start at the lowest dose in those patients where there is hypotension, and slower up titration. Be patient, slow, go up very, very slowly. This is all the more true in patients who are not on full dose of ACE or ARB, or who are naive to ACE or ARB. Go slow in these patients also. So start low and go slow. As far as potassium is concerned, first look at drugs which increase potassium, potassium sparing diuretics or potassium supplements. Next, look at dietary potassium, fruits, for example, and use of other concomitant medications, NSAIDs, again, another example. And finally, be careful in patients with renal impairment, diabetes, hypoaldosteronism, high potassium diet. So monitor these patients very carefully. In fact, potassium is the most dangerous thing because neither hypotension nor worsening renal function will kill a patient suddenly, but hyperkalemia can lead to sudden cardiac death. As far as worsening renal function is concerned, 25 to 30% reduction in GFR is expected. Like ACE or ARB, 25 to 30% reduction in GFR is expected. If it goes beyond that, one has to down titrate the dose of valsartan sacubitril and then maybe increase further depending on what happens to the renal function. And of course, be careful in patients with severe renal impairments. So what are the current indications for ARNI? Which are the patients you will give for the current indication for ARNI? Well, number 1 is the patients who have been included in the Paradigm heart failure trial. These are stable ambulatory heart failure with reduced ejection fraction patients, already tolerating doses of ACE and AR, and who continues to be symptomatic despite optimal management. Now, all these are important. You don't treat an acute heart failure patient, they should be stable. The trial is on patients who are already on ACE and ARB and is tolerating these drugs. And finally, in spite of ACE and ARB, they are symptomatic. So asymptomatic class 1 patients, there is no rule for ARB. Now, what about those patients who satisfy all these criteria, except that they are not on ACE or ARB, which means newly diagnosed patients? Now, both American Heart Association and the European Society of Cardiology now says that these patients also, you can start on neprilysin sacubitril valsartan combination because of the benefits, the high benefits that are seen in the Paradigm heart failure trial. And also, you can avoid the problem of switching from ACE to ARB to sacubitril valsartan if you initially itself start these patients on ARB. So heart failure with reduced ejection fraction, not on ACE, ARB, newly diagnosed, again, you can start sacubitril valsartan combination. But in acute decompensated heart failure, there are some trials looking at the BNP levels, but there is no trial looking at mortality or morbidity. So as at present, it is not a labeled indication. The same thing is true in heart failure with preserved ejection fraction. Some trials are there, but the results are disappointing. And finally, as I said earlier itself, let me re-emphasize, remember these 3 values: systolic BP less than 95, eGFR less than 30, serum potassium more than 5.4. Don't start ARNI in this group of patients. History of angioedema with either ACE or ARB is another contraindication for ARNI. So to conclude, ladies and gentlemen, heart failure prognosis is worse actually than many malignancies. Optimal medical therapy has improved the survival of heart failure with reduced ejection fraction. ARNI, on top of currently recommended optimal medication, has further improved not only the morbidity but also mortality in heart failure with reduced ejection fraction. Stable ambulatory heart failure with reduced ejection fraction patients tolerating ACE and ARB is the class 1 strong indication for ARB. Acute heart failure and heart failure with preserved ejection fraction, we will have to wait for more data before starting ARNI in these patients. Thank you very much.